Hello, good evening, ladies and gentlemen. Welcome to the second day of a volunteer training program. Today, you'll be learning about empathetic communication, effective communication, barriers to effective communication, good and bad communication, listening skills, etc. All these nuances of communication would be communicated to you by Mrs. Mariam Joseph. Is a professional social worker, counselor, and trainer working in the field of palliative care since 2007. Sorry, my video went off. She has done masters in social work, postgraduate diploma in hospital administration, certification in counseling, and also PG diploma in human resource management. She's Pallium India's very first social worker. She has also worked in various other capacities as counselor, supervisor to social workers, volunteer coordinator, head of training division, and assistant manager, human resource management and fundraising. She is now settled in Dubai with her family, where she continues her practice as counselor, trainer, and mentor to social workers from around the world. Warm welcome to you, dear Mrs. Aneeja Joseph, and over to you.
Thank you, Shanti. Thank you, Pallium India team. And hey, welcome everyone. So like Shanti introduced, my name is Aneeja. I'm happy to be of some assistance to Pallium India today to speak about communication. I will not say I want to speak. During this 1.5 hour session, let us together have a dialogue. Communication, when it is one way, it's called monologue, and it is not a communication at all. And I, for one, don't like preaching. So throughout the session, if you have any doubts, any queries, please put up the hands. Do not wait for the end of the session. You can put in your comments, your questions in the dialogue box. So I was told today that we have an audience of diverse age group, starting from students to people who are already working in palliative care. We have chaplain, we have doctors, we have healthcare professionals, we have homemakers, we have students in school, we have students doing their undergraduate, postgraduate degrees as well. So I was told to take communications and basic communication skills. Okay? So we'll talk about something that we already know. So the question always arises, why do we need to learn about communication? Isn't that something we do from the time we are born, isn't it? So why learn about it? Is there a need? Isn't it a waste of time? We'll talk about all that in the context of palliative, especially in the context of palliative care. So let's start the presentation. So Senia, will you be displaying it or?
We have given you rights, Aneeja ma'am. We have given you the rights for screen sharing.
Okay. All right. You have to help me out with this. I'm not too good at.
Okay, we are sharing from our end.
Okay, thank you so much. Perfect. So can we go to the next slide, please? So today we will look into, like I said, the importance of communication in palliative care. What are the possible barriers? What are the things that we should try and avoid? And by doing this, like by avoiding the barriers and by intentionally following certain do's and consciously avoiding the don'ts, how can we be an effective communicator? Next slide, please. We also would like to look into who does it help and how does it help? Who in the sense, when you look at palliative care, next slide, please. Next slide. So if you look at the WHO definition, it says that the quality of life of patients and families. So this is where the who comes in. It is not limited to just patients and families. It also involves the team. It also involves the community and the nation at large, right? So in communication, our ultimate aim is, or the focus is, the quality of life of patients and families. It's very important that I'm sure I was also part of Rajuba's training yesterday, and he did introduce the concept of total pain, right? And he did mention that there are 4 aspects to pain: the physical, the psychological, the emotional, and the social pain. So these communication is, therefore, the quality of life is comprises of all this. It is not just relieving the physical pain, but also ensuring their emotional, social, and spiritual well-being, right? So if we continue reading the WHO definition, it says quality of life of patients and families facing problems associated with life-limiting illness through prevention, relief of suffering by means of early identification, impeccable assessment, treatment of pain, other problems like physical, psychosocial, and spiritual. So even the World Health Organization has accepted that it is not just enough to identify or address the physical issues, but it is equally important to address the psychological, social, and spiritual issues as well. So there comes in the role of communication. I understand Shanti is also a counselor. So please feel free to jump in anytime with your contribution as well. And she's, as you're also a volunteer, has already been working in palliative care. I'm sure you'll have definitely have something to add, and your contributions are welcome. So if I and also all of you, if there's anything that you feel you have to question, you feel like challenging, please feel free to do so. So next slide. Coming back to the question, who and how. Okay, so first let's focus on the patient and family. It helps in giving a clarity of diagnosis, prognosis. Diagnosis is what is the disease. Prognosis is where we are now, what is going to happen in the future. Why is it important to communicate? Why is it important to clarify this? So let me give you a story of one of the patients that I came across recently. This is an 94-year-old woman, a widow, who's being taken care of by her son. She's been having stomach cramps for some time now. She's quite mobile. She's quite active. She's a very cheerful person with a very strong positive outlook to life. She has, she loves being with people and all that. So that is her general character or attitude to life. So since she started having the stomach cramps, she like I said, she's 94. So you can imagine she is from previous generation where women, are really strong and they have put up with a lot of troubles in their life. And so she's one such character. She never, why I say that is because she put up with this abdominal pain. She did not communicate it to the family because she didn't want to trouble her son. So she kept it to herself. Eventually, when she couldn't tolerate the pain anymore, she discussed it with one of her granddaughters, who's a doctor. So one day she had collected her motion and kept it in a container. And when that granddaughter came to visit, she showed her, and she said, you know what, this has been going on for some time. I'm having loose motion and the motion is not right. This is what is happening to me. And the granddaughter being a doctor, one look at it and she felt it's not right. She said, you have to get that checked. So they went to the doctor. The doctor did a detailed colonoscopy, and they found out that she has stage 3 rectal cancer. Yes, do we tell should be told? How much should we tell them? All these questions arise, right? So the doctor discussed or communicated what the but to the grandmother, she was told she's having piles. They never told her she still doesn't know that she has cancer of rectum. So there is an issue there which will come to later. But if the family had continued thinking that this is just another abdominal cramp, or this is just loose motion, how do you think it would have affected the family? Do put in your comments. Okay, to put in your comments, I would like to know, what do you think? Why was it as important, or why was it important to, or how does it help the family? Yeah. See, many times when we don't have a clear understanding of what is happening with us, even if it's a simple headache, imagine one of us have a headache and it continues for a few days, it lasts for weeks. Don't we get upset? Don't we get worried? We do, right? To know what is going on and what can we do about it really gives a sense of relief, right? Knowing what exactly that you're dealing with, it helps us to plan the coming days. Being in the unknown, that uncertainty, that itself causes a lot of stress, that causes a lot of emotional distress, which in turn can again affect the physical realm, right? It helps us to plan for the future days, the clarity. So it is important. That is why communication is important. It gives us, like the rest of the slide says, it helps in giving a sense of direction. What now? So once a grandmother or the caregiver came to know that this is, this is cancer, this is third stage, what now? They can plan. Where do we take her? Things like, does she need a continuous caregiver? What is the next line of treatment? Where do we go from here? Do we go to a private hospital? Do we go to a government hospital? What is the financial implication? Okay, and what is the next line of treatment? Is this something that she can, her body can, take on? Does she need radiation? Does she need, will she need a colostomy bag? If she needs, who is going to take care of all that? All this is very important for the family, for the patient. So it leads to informed decision making. And when we communicate, when we share the information with the family, it gives them that, it gives the control back to them to take an informed decision. Okay, this is what we want. We understand this is what the situation is. We understand this is the scenario. These are our limitations. These are our strengths. Considering this, what can be done? Well, how can we go forward? So it is with their consent and it is with their involvement that a decision is arrived at. They'll also have doubts. We had a patient at palliative during my very first year, where the patient had cancer. Again, she was a cancer patient. She had 2 children, 2 boys. Her husband had left her long back. So she was the sole parent, the breadwinner, the companion, the friend to her children. The eldest boy was just completing his school and the youngest was very small. So throughout the caregiving, It was her sister who was involved, or sister's family who was involved, more involved in taking decisions and, giving care, because they didn't want to disrupt the boy's education, upset him because he was doing his final exams. They kept him away. But eventually, when the situation got worse, we made it a point to bring in the son. We insisted that, it is better for him to come in and understand what's going on. So once we brought him in, you won't believe he had a lot of doubts. You'd be surprised. I was surprised to know that they didn't even tell him that his mother had cancer or she was dying, that there was no coming back. So he kept thinking she had some issue that need a prolonged care, and that is what is happening. Clarification of doubts, that is what we mean. One of the reasons why communication is important. Telling them what is happening, help them understand what is happening, right? And so that once the inevitable happens, it is not as much as a shock it would be otherwise. Like I said, the financial burden, how do we go forward? The majority of our population, or the patients that come to us at Palliative India, belong to below the poverty line, right? There are times when we had a patient who had cancer of his tongue. He and his wife sold everything they had. They had few cow from which they sold. They had goat, which they sold. They had 2 daughters. The younger one stopped her education. Like I said, they sold their house. Eventually, what happened is the daughters were put up with their neighbor because they didn't have a place to stay. They will come to the regional, they'll come to the cancer center for their treatment in the morning. They will go after their treatment. They go back to the church that is nearby, and they used to sleep on the courtyard of the church. They used to spend the night at the church courtyard. Right? This was the scenario. So from below poverty line, they've gone further down. We have families who belong to above poverty line, or from a higher middle class or higher class, who can afford to take treatment, but who can afford, finance. They don't have a financial problem, and yet by the end of the treatment, they are in debt. So we need to share with them what are the other options. Is this something that they want to take on? Is it something, rather than telling them, you have to do this, you have to, or the patient will die. Of course, that we may have, that treatment may be very necessary, but tell them the financial aspect, discuss with them what is involved, so that they get to decide how to go about it. It also helps in resetting priorities and giving them realistic expectations. You know what? Why I say resetting priorities is because I've had a patient who told me this. She said, everything was going smoothly until I got the report, the blood test report. It just took 1 second to turn my world upside down. Meaning, when you look at a patient or the family, what we think is their priority may not be their priority at all. You might come across patients who have a pain score of 9 out of 10 or 8 out of 10. And it's easy to assume, it is natural to assume that of course, their main issue is pain. But if you talk to them, like in the video that Raju Balsa showed you yesterday, the Smriti was sharing, the pain, what must be worrying the family must be about something else. Or there is brother with whom he has had a grudge and he hasn't spoken to for the last many years. There's something else to be done. I want to make sure, I want to see my daughter's wedding, so an open communication helps them to reset their priorities. It keeps in a reality check. Like it helps them to plan for the future in a sense. Once we go back from the hospital, once we complete the treatment, what next? How do we go about it? Like in this case that I mentioned earlier about the 94-year-old lady who has rectal cancer. She has stage 3 cancer, but she's doing well now. She had her radiation. She had her surgery. She's now on colostomy bag. Now she is sent back home. But now what? Who will help take care of her? She has only her son living with her. And she's a woman who wants her privacy, who doesn't like to burden anyone else with caring for her. So how do we go about it? Things like that. Who else is there to take care of the family at home? If it is a patient who has a spinal cord injury or who has met with stroke, how do we go about it? What next? Is there someone else to take care? What are the medical support that they will need? Is there an emotional support system for them? So all this, not just for the patient, but also for the family. Well, is there only one caregiver for the patient? If in the long term she might have a burnout, who else can come in? Is there an option to give her respite care? These are all things that we need to communicate with the patient and family in the context of palliative care. Next slide, please. So far, do you have any questions? Are there any questions so far?
No questions, I believe.
Okay. So the next thing is the team. The team, can you just go to the next slide? We'll come back to this. So this is how I see the team. Patient and family caregivers at the center. And all of us are equally important. And we form the team. And there is no hierarchy in this. There is no team or no person of greater importance or lesser value. Each of us play a crucial part in giving quality, good care to the patient and family. So why is it important for us and how will it help us? Can we go back to the previous slide? Trust. So trust, by trust, I mean it is building, when you hear the word trust, I'm sure all of you will naturally think that the first line, second line, both of them, both the points are connected. Trust, once you earn the trust of the patient, it helps in better establishing a better rapport, better relationship. It means less stress. Once you trust a person, you tend to believe them, tend to accept what they say better. There is no lesser doubts. So it brings in a lot of credibility to what you're saying, right? So in any relationship, not just with patient and the caregiver, or when I say the caregiver, I mean all of us. In any relationship, we all know that if trust is broken, then whatever we say or do, it's hard to believe him. It's hard to believe that it is what they're saying or doing is for our good. So this is very important. Earning the trust, and it has to be earned. It doesn't happen at the snap of a finger. It has to be earned. When you go to a doctor, when we go to certain hospitals, when we take a feedback from the layperson, you say, okay, go to him, he'll give you an unnecessary list of investigations. When you talk about a hospital, they are just, it's not service, they're focusing on business. We've heard things like that, right? It's not just about doctors. When you go to any scenario, any situation, when we know there is no credibility to the work that they're doing, then it is difficult to earn the trust. So once you earn the trust, like I said, better relationship. If you have a better relationship, it helps in better planning, better plan. And this is not, like I said, not just with the team, not just with the family or caregivers. It is, it's a 360-degree thing. It has to come from within to all our team members as well. We should be able to trust our team members. So and we should be able to trust not just the people that we're directly interacting with within the team, but also outside our organization. When they pass on an information, we should be able to believe that, there is credibility, this is honest, there are no hidden agendas. This is for the welfare of the patient. Ultimate aim again, quality of life. So it is for the welfare of the patient and the family. Helps in better planning. Better planning in the sense managing the caseload. Why is it important? It helps in time management. It makes sure that you give quality time with the patient and the family, and also with the team members, also with our family members, right? Family is also important. There has to be a balance. Like I said, it helps in comprehensive care. Unless if you don't see eye to eye with I am a counselor, if Ms. Shanti is also a counselor, but if you don't see eye to eye, if there is an unnecessary competition between us, it won't work. It won't help the patient. It won't help us as well, right? So there should be a good relationship between all the team members within the organization, outside the organization, with the family, with our own family. And also it is important to have a good relationship with ourselves. I'll come to that part at the very end of the session. It's all about self-care. It's also important, I stress that. We'll spend a few minutes on that because it's very, very important. Like I said, so once you establish trust, communication helps in bringing about the credibility, less stress, few complaints or litigations, or, it helps promote better service, all that. As a team, when we work together, this is what communication can help us achieve. Next slide, please. Next slide, please. Thank you. Again, coming back to this, the public. So when we do our job well, when we provide proper care, when our patients and families are satisfied with what we do and what we say and how we do it, it reflects in the society. It's the first and foremost thing is, I think it helps in understanding. It helps the community, the society at large to understand what palliative care is. I think one of the biggest misunderstanding is palliative care is all about death. If you go to palliative care, it means there is nothing else to do. You're going to die. I've heard people say, we don't want to go to palliative care because if you enter palliative care, you're sure to die. Again, a wrong understanding. Then there is a stigma attached. One case that I clearly remember is about a little boy that I met during one of our home care visits. He must be like 8 or 10 years old. When we went to visit this family, the boy was outside. It was a school day. So I asked him, aren't you at school? And he said, no, I don't go because we can't afford to do so. I said, okay. So then what do you do? I said, I just hang around. Don't you have friends? We used to have, all of the families around. My grandfather have built this house. So we've been here for generations. So all the families around are people that we know from a very long time. But ever since my mother have had cancer, people have stopped talking to us. People don't interact with us. In fact, the auntie, the next door neighbor, apparently told her son not to play with him, this boy, because if he does, he might also get cancer. So there's this misunderstanding that cancer is a communicable disease. It's like, and the trauma that the family experiences, the children experience, even people with cancer, many times organizations are not willing to employ them. A lot has changed now, but earlier, because of the financial burden of probably employing a cancer patient and the stigma attached to it, these are all because of wrong information, wrong communication. So in communicating the right, putting across the right message, telling them what palliative care is, rather than preaching, if I come and tell you this is what palliative care is, depending on where my credibility is, you may or may not believe me, right? And if for example, if I go and tell a patient that, a paraplegic patient that, tomorrow you're going to, don't worry, you can get up and walk with physiotherapy. He might ask me, who are you? What is your background? What is your experience? And if I say I'm a social worker, it is not credible enough. But if a physiatrist or a physiotherapist tells him that, it has more value. Similarly, when we as palliative care workers give the right information through our work, through our communication to our patients, that's good enough medium for the society to understand what palliative care is, right? So it sets realistic expectations from the palliative care community. It lessens suffering. When I say lessen suffering, it means more people will be open to accessing palliative care when they understand it is not just about death, that it is not a communicable disease, that there can be pain relief, that this suffering is unnecessary, and there is more to it than just physical care. I'm sure more people will be able to reach out. They will come, which means less suffering, which means more quality of care. Again, coming back to WHO definition. Next slide, please. So far, any questions before we move on?
Yes, ma'am. Hi, this is Vijay, ma'am. See, actually, recently I came through one of the case. So the patient was suffering from cancer, okay, and GI cancer, and he lost his life after the surgery. Okay, but the thing is that more people don't know about this palliative care, and as you said, the people are thinking that it is, if you go to the hospital for a palliative care, and that is the end of the life, they won't come back to home. So this is the, this is the thing which they have in their mind actually. So how can we take this palliative care to the more number of people? Because more number of people are not aware of this what palliative care is actually. Even the educated people also don't have any idea about this palliative care. Even I have seen in I'm working for one of the tech companies in India. So I have my colleagues and managers and so many people, like they don't know even about the palliative. They didn't even heard about palliative care. How can this be reached to a greater number of population?
So may I know your name, please?
My name is Vijay.
Vijay. So Vijay, you've actually asked a very, very, very important question. This is more, like I said, this is more to do about the misunderstanding, the lack of information, it's about communicating with the public. It is about taking an active interest in sharing the information. The thing is, it's already out there. It is available. It is just that the people don't know about it. We'll come to this. We'll definitely take up your question in more detail towards the end of the session. Shanti ma'am, if you could just remind towards the end of the session, we will talk about this in a little more detail and how we can make the public more aware.
Yeah, sure.
Thank you. Okay. So I'm just moving on to the next slide. We'll talk about, no, don't go to previous slide, please. Yeah. So if you take a look at you saw the title, Barriers to Effective Communication. One look at the picture and I think it just, it talks a lot, isn't it? Right? So, so these are all things, what I'm speaking today are all things that we all know, just refreshing or consciously trying to learn and unlearn a few things, okay? So if you look at it, or look at the image on the screen, you can see there's one picture at the bottom. And there are about 1, 2, 3, 4, 5, 6, 7 people trying to interpret what it is. Same image, 8 different or 7 different interpretations. 1, 2, 3, 4, 5, 6, 6 interpretations. This is what happens to 7. Yeah, thank you. One person hasn't even bothered to think about it. So there are 7 people, one person has no clue what it is, and 6 different interpretations, right? This is what happens. So we'll talk about, again, communication. Basically, communication you have to understand is mostly verbal and non-verbal, right? And so far from observing me, you would have understood that I'm a very animated person. It is not intentional. I can't help it. There's a lot of expressions. I use a lot of hand gestures. I try to stay still, but it doesn't help. All of us are different. It works differently for different people. So let's take a few moments to now look into the barriers, probable barriers to an effective communication. So next slide. Let's look at our environment. Take a moment and think about what all you did today to make sure that when you attend today's session, you will not be interrupted. Just take a moment to realize. Just take a moment to ponder on it. If there are mothers with young children, what did you do to the child? How did you soundproof the room that you're sitting? If you are in a place where it's evening now, or if it is another time zone, how do you make sure that you're not sleepy, you're awake? If you're attending a session after a long and hectic day, what is it that you have done to make sure you don't fall asleep, right? Points mentioned in this slide is exactly talks about that, the physical barriers. Physical barriers could be, I can show you one thing that's on my table. I don't laugh when you see this. I don't know if you can see. I don't know if you can see me. Or Firia, can they see me now?
Yes, you are visible, ma'am.
Can you see what's on my hand? It's a toothbrush.
Toothbrush.
I have a 2-year-old who I was trying to, get rid of from my room, and this is what she finally left on my laptop just before the session started. So what I'm trying to say is so many things that I have to push away, make clear, make sure that I look presentable. I don't look tired. There's enough lighting in the room. There is enough that I don't feel exhausted. I've tried to soundproof my room. I've turned on the AC. It is cold for me, but it'll just keep her voice out so that the class won't get disturbed. Little things, very little things, but it makes a world of difference. The lighting, the ambience, the sounds, the noise in the background, the technology that we use. If Senior hadn't helped me, we would have been stuck today. I have no clue I didn't know how to access or display a PowerPoint presentation. All this is equally important, lack of privacy, especially a lack of privacy when you deal with, when you talk to patients and their family time. All this is very important. How do you make sure that these are addressed? When a patient comes to your clinic, or when you go to their home, if you're doing a home care visit, or when you're talking to the family members, as volunteers, it matters. The physical barriers, which include our the way we're going to sit and talk to them. If you're going to sit at a table and talk to them, in the picture, if you look at it, there are two people sitting and talking. A person is having a paper in his hand, probably a report. That guy must be a doctor. We are seeing the shadow, but you can see that they're sitting face to face. There is no clutter of things like toothbrushes, pens, books, water bottles, or anything standing in their way. There should be enough light. There should be less noise. And talking all this will, there may create the right environment. And also, let's take a moment to speak a little more about privacy. How do you ensure privacy? Many times, if you're especially a healthcare professional, or if you're visiting the patient and the family as a team, how do you ensure there is a privacy? It's very important. Even, if you're married, you have a family, if you're part of staying with the family, I know there are these moments in your life. There have been moments in your life when you wanted to communicate something to a person that's very important. You want to share a secret without the third party being known. So what did you do? Think about it. Many times it's more than enough. You may not get a private room to sit down and talk to the patient, though it is very important. It is important that it should be able to at least create that illusion of privacy. When you're sitting down and talking to a patient, please make sure that you give them the full attention. That itself will create an illusion of privacy. If you can pull the curtain, block the people from the other people in the room, do that. If you want to move to a corner and speak. Because privacy means just place yourself in that person's shoe. It is important. It shows the respect you have for that person as an individual. It shows that they deserve that respect. It shows that we treat them with dignity, right? And the last point is time. There are many times when you're burdened with a lot of tasks, responsibilities, and we don't have time. But, one moment is enough to make that person feel valued and heard. It is that how you spend that one moment. If you don't have much time, it is always important to tell them if you feel there is the patient wants to talk a lot and you don't have that much time to spare. Even when you sit down, I think it's important to clarify to them, I understand this is the issue. We will come to it. Right now, I have probably 10 minutes, 15 minutes to spare, but I will definitely get back. Even if you don't have so much of time, if you have just few minutes, 5 minutes, spending that time with full attention makes a lot of difference. So time, whatever time it is, seconds to minutes to hours, give them their full attention. Next slide. Right. Patient and family. These are things it will be good to bear in mind when you meet them or interact with them. Personality, we are all different, isn't it? I said that's the uniqueness and that's the beauty of it all, right? I can tell you in my family, I take my family as an example because it's safe. So my mother is a very jovial, talkative person. I keep saying my father is the hero of an art movie. So you give him 1 hour, 10 hours later, he'll be in the same position, no movement, no emotions, no expressions. So my mom will be very expressive, very animated, very talkative, whereas my father is not. He's a very reserved, very quiet, very shy person. It is important. Two people, same house, same roof, how they see things, how they understand things is different. It's important to, why I say this is, why I quote this example is because when I present it's to to show you that when as children we take our problems to our mother or to our father, we use a different approach depending on their personality, depending on their mood, right? Similarly, when we deal with our patients and their families, we need to understand that they are more than the disease now, and there is a probability that disease has changed or affected their personality. Someone who was a very outgoing person, someone who loved to meet people, after having cancer of the cheek or tongue, may not want to meet people. He might be angry. He might be basically, maybe he's an outgoing person, maybe he's an extrovert. He was. Now, family says he's no longer like that. He's difficult to manage. He's very aggressive, or he's very depressed. Or you might also find family members who are overbearing, controlling, saying that no, you don't have to talk to the patient. He doesn't have to know. No, we are the decision makers. No, I say that overbearing, controlling. So many times we have to understand that is their personality. They are not even aware of the damage that they're doing or the hindrances that they're causing to ineffective communication. Emotional state. The disease must have affected them in different ways, right? They might be confused, shocked, denial, overwhelmed, maybe all of them at the same time. They are feeling so many emotions at the same time. So we must be respectful of it. Social conditioning. I say this. See, there are several theories. There are several theories that try to explain communication. So, and there are several interventions based on these theories that we use in addressing psychosocial issues. So, when we talk about social conditioning, see, probably 100 years ago, when a patient comes to the doctor, or when all of us, or when our grandfathers went to the doctor, to a medical facility, they probably tell, doctor, I have a tooth pain, finish. Or I have been having this tummy ache for the last 10 days. We don't ask for the doctor might prescribe something, we'll take the medication. We might not even know what it is. You ask the patient, you say it is a pink colored tablet or it's a blue colored syrup. That is all. So, but now that was how the society was back then. That was how the culture of communication was back then. Doctors said, I obey. Or the medical professional said, I obey. No questions asked. Now things are changing. People are more aware of their rights. They are more aware of the lot of information available on Google. There are a lot of wrong information as well. So they know their rights. So like, they're the more aware, more knowledge and wrong information, all this because it's changing. It's a dynamic situation. Social conditioning, always there is an element of social conditioning that is evolving, that keeps changing. So we have to bear in mind when you talk to a person who is 80-year-old, and it is not just his personality or the mood that he's in, it's also the culture, the era that he was brought up in may have a lot of influence. I'm not saying it will, it may influence a lot. So sometimes you may have to do a little more probing into, asking them more questions. Sometimes you have to take a step back. Sometimes you just don't have to ask any questions, and the new generation will keep bombarding you with a lot of questions. Lastly, unable to speak because of the disease. This is again connected to personality and emotional state as well. Because of the disease, they might not be literally cannot speak because of they're in pain, because of any physical agitation, or because of emotional distress, because of any other burden that they're feeling at the moment. We have to be mindful. We have to be very conscious that these could affect. Next slide. So, have you ever thought about this? Are we a barrier? I'm a social worker. My intention is only to help. How can I be a barrier? I'm a volunteer. I've taken my time, energy, and my resources have come here to help. How can I be a barrier? Any comments on that? Okay. So let's move to the next slide. I would like you to take a moment to watch this video and senior, towards the end of the video, there is a slide explaining bullet points. Just stop before that. Okay.
Aneeja ma'am, just give us one moment. We are facing a small technical glitch. Coming back in a moment.
Okay. Okay, in the meantime, then let's just try and answer the question. Do you think we are a barrier? If we are, what are the things that we are doing unintentionally to hinder our communication? I'll look into. Elaine, is that for me? Please don't cover your mouth when speaking. Those hard of hearing need to see your lips. Sorry, I'm sorry, everyone, if I did that.
No, you didn't. It was one of the questioners.
Okay.
So no, you've been very clear. Thank you. I would just typing. It takes me ages to type in. One way we can be a barrier is if we talk too much,
right,
and we don't listen enough.
Absolutely. So one of the mentors from whom I learned a lot about communication used to say, you know what, God is very wise. You know exactly why he gave you 1 mouth and 2 ears. So do your job well. You know, talk less, hear more. So that's what you said is a very, 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 I mean, I think it's the crux of communication skill, Elaine. That's what, that is something that we have to do. Talk less is one aspect, but more importantly, listening. Listening. Yes, you're absolutely right, Bhavna. We may judge them for many reasons, which is something we will definitely look into. Senior, if it's taking a while, why don't we skip this? I will come back to this later anyway.
Unable to sleep at night.
Mr. Arun Kumar
That
is
happens
suffering
to me
from
too.
lung cancer.
I hardly sleep
Radhika
these
is
days.
his wife and
It is so
caregiver.
hot at night.
Asha worker Raji is visiting them at their home. I am
Senior,
with
I think it is, the voice is jumbled.
Okay, yeah, tell me.
Just give me one.
Come. I'm busy today. Radhika, I'm with the patient.
Why don't you give him something to eat? Didi, I'm so glad you could come. Please have a seat.
No, I
Senior,
can't
let
sit.
me make a suggestion. Let's just hold on to this. We'll play this towards the end of the session.
When I force him, he gets angry.
I don't.
Okay.
We'll move on with the slides and come back to this.
Give him something to eat.
Okay? Thank you, sir. So the next few slides, we're going to take a honest, next slide. Yeah, in the next few slides, we will look honestly at ourselves. Senior, next slide. Next slide. Yeah. What may be some of the personal factors influencing our communication? Okay. It is just an honest, critical look into ourselves as a person and also in our professional capacity. Be it whatever, student. I see a reverend here, so happy to see you, sir. I'm sure there are other healthcare professionals as well. Just explore together what may be some of the factors that we are not even aware of, apart from a physical and verbal, non-verbal and all that. Let's see what it is. Okay. Next slide, please. I'm sure all of us have heard about the iceberg, right? Iceberg, they say it is only a very tiny bit. I forget the exact how much portion is about. They say one by something. Okay, let's leave that part. But as you can very clearly see from the image, you can see much of it is hidden underneath. Now, bearing that in mind, let's take a look at the points. The family dynamics, style of learned communication, the generation, like I said, the generation that we are born in, our own life experiences, attitudes, education, our culture, nationality, gender, sexual orientation, language, values, and religion. There's so many points, isn't it? Let's just start the family dynamics. I'll take myself as an example. And I'm in my family. I have an older sister. I'm the younger one. My father, mother, me, and my sister. That's my family. Till I got married. Okay. So I was raised up in a family where I don't have a boy sibling. Right? I was raised in a family. I'm part of a family where there is open communication. And I'm the younger one, which means I'm more naughty, I'm told. So I get to speak, or I tend to speak my mouth. I'm more vocal about my thoughts, my objections, my ideas. This is also because my father and my mother, I feel, are very caring. One is very expressive, the other one is not expressive. One is very expressive to a point that there is emotional blackmail, where the other one is more on the angry, temperamental side. So, but all said and done, I know they're very caring, they're very supportive. Being a girl, they've never stopped me from taking on a challenge, trying out something new, going out with friends. So this is the circumstance that I was brought up in. Post-marriage, I'm married to the younger one in the family. He's the only boy in the family. He even now doesn't raise his voice against his father. One look from his father and he will run to the room. He'll be like, shush, not now. And I'm like, why? He's your father, tell him he can't do it. I said, no, don't raise your voice. So that is day and night difference, right? We need to know so what we think. So this is how from my family I learned, it is okay. You can speak to your father. He is your father. He loves you. He might scold you, but he still loves you. But you as a person matter, you can raise your voice. You can raise your voice in the sense you can speak out. You can state your opinions. Your opinions are valued. They could be considered. I am of this. My grandmother came and stayed with me for some time for a long while. So we used to have these long fights. I like staying up in the night. My grandmother wakes up at 3 in the morning. But so we used to have these arguments. She used to say, women are supposed to get up at early morning, 4 in the morning. What are you doing? Staying up at 3 in the night. She never understood of late night work. Even she says, your work ends at 5. Why are you late? Coming home at 8. She doesn't understand. There's a generation gap. Things like this. Life experiences, how we view life, how we respond to things, how we respond and how we react to situations, our education. See, like I said, I'm a social worker, a professionally trained social worker. I have a master's degree in social work. So that makes me what? Professional, trained, well-equipped. Right? I also have a certification in counseling. Great. All great. But in reality, how does it help me? Is it helping me or is it hindering me? It's good to have it is good to have knowledge. It is good to have life experiences. But is that the ultimate answer? No. How you have experienced, how you have reacted to a certain experience in your life, it will not be the same way someone else responds. Losing a child is traumatic. It's very traumatic. When someone says, when a person shares her experience about losing a baby or losing or about abortion, we can understand that, but we don't fully understand it. How much ever we say we get you, we don't, unless we lose a child, right? It's different. When we lose, my father lost his mother to cancer at a very young age. I was always empathized with her, but I never knew that grandmother. I never met her. His mother died when he was 30. My maternal grandmother now has been diagnosed with cancer. Now, as a grandchild, I know I've been working in palliative care, but now having a family member makes a world of difference. It's different. I'm worried when she says something. I'm more open. I'm more. I tend to reach out to more people. I'm more proactive. So now sometimes I used to wonder, why can't the families just stay put? Let them be. It is important. But now, as a granddaughter who's in palliative care, I feel it's my responsibility to do. It's difficult to stay back. So again, life experiences, our education, the culture that we are brought up in, our nationality doesn't make a difference. Do we tend to be biased? Do we tend to be prejudiced if we hear that they are from that country? Or again, gender, sexual orientation, we tend to say we are very open, but are we truly socioeconomic class? Do we tend to stereotype them because of subconsciously nothing might appear on our face, nothing might appear even in our interactions perhaps, but is it there somewhere deep down? That is, and if it is, how is it helping us or is it blocking us in some way? Our value system. I have a social worker. I used to work with a social worker who's an atheist. I'm a Christian. Is there a conflict of interest? Can we work along well? There is our focus. Is it the patient? So do I trust her judgment on social work interventions for the patient? Because is it hindering my respect for her? These are all things that we need to look into, critically analyze. Next factor, and next slide, please. We quickly look into this. Are we a talker, thinker, like Elaine rightly said, talking and listening? Do we tend to think a lot? Are we an extrovert? Are we an introvert? Or are we a third category is an ambivert? Are we that? Are we a leader? Or do we tend to follow? Are we more people-oriented or task-oriented? Are we a team player or loner? Why we need to look into all these traits or all these things. This will help us understand our strength and our weakness, or not weakness, our challenges in being effective as a communicator. And these are, once we know which category we fall into, which area we need to work on, we can improve our skills. Next slide, please. So basically, it is all about making our communication very clear. It should be concise, it should be complete. So before you open your mouth, think. Till you attain that clarity, think. You cannot randomly throw words at people. You cannot randomly use non-verbal cues. When somebody says something, you give them a look like, oh, and then say, oh, I didn't mean anything. Then you go look at somebody when they talk, you sit like this. And then say, no, really, I'm actually interested. It's just that I'm actually interested. Verbal, non-verbal cues, whatever it is, it has to be very clear. It should be short, crisp, for the person should understand what you're trying to say, and it should be complete. And for doing that, you may have to learn new skills. You may have to unlearn certain skills. You may have to let go of certain traits in you. You may have to learn. Next slide. Okay. Can we use the video now?
Yes, ma'am. Sure.
The question is, what do you think was wrong or not good or essentially unacceptable in the way the lady did, or the ASHA worker communicated to the patient and the family? So ASHA worker, for those who don't know, are healthcare workers, community healthcare workers employed by the government. It's to simply put. Can you put in your comments quickly in the chat box, and maybe we'll read a few of them. Can you tell what was bad in this communication, or what was wrong, unacceptable? No concern. No concern for the patient's pain or the caregiver's distress. ASHA worker was busy. Yeah, she walked in with her phone. She was still talking on the phone when she came in. When she was offered a seat, she didn't sit, she didn't give proper time. The lady wasn't listening to the patient. The lady wasn't listening. Very crucial point. Everything, her behavior. I don't speak Hindi. I know dialogue. Okay. I hope I read it right. Empathetic listening. Yes. Again, the common point here I see is empathetic listening. Yes. Not compassionate. Absolutely. Absolutely. So again, let's continue with the slides. So you are all spot on. The essence of what went wrong was she wasn't listening, right? Somebody said she wasn't listening to the patient. Okay. We'll explore that in the coming slides. I'm going to rush through a bit because of lack of time. Next slide. Let's start with the obvious thing. Eye contact. So in this video, you can see that she did look at the patient. She did look at the caregiver. From the video, it was obvious that this is not the first time that this was not her first visit, because the caregiver did say, "I'm glad you came, Didi," right? But many times, let's imagine another scenario where you're seeing the patient or the family for the first time. So eye contact is very important. Even when I'm doing this Zoom meeting now, it is so encouraging to see faces. When I see, rather than speaking to a blank screen with just names, so many haven't come on screen. I'm sure you have your own reasons. I also do that. I'm not blaming anyone. There might be a lot of restrictions at home. I understand. But when we are there in person, or talking to them over Zoom, counseling them over Zoom, or trying to get resource mobilized for them, when we are in contact with the patient, it is important to have eye contact. But at the same time, avoid staring. I emphasize that because some of us are not good with communication. These are all non-verbal cues. So with all this enthusiasm to practice what we learn in communication, don't go ahead and stare at the person, right? So we learned point number 1 was to give a good eye contact. So I have to look. No. It is not staring, it is maintaining eye contact. It should not look elsewhere. especially when you talk to a person of the opposite gender. If you are a male talking to another lady, maintain the eye contact of face. Don't go below the chin. It is unacceptable. It is inappropriate, if at all. And also, when you maintain eye contact, it is actually difficult for the person who's being looked at and the person who is looking to keep looking. It is important to look away. It is natural to look away, right? So it is important that you need a break. Your eye needs a break. It's a natural response. So when you look away, don't look at your time. If you need to look somewhere else, if you can't keep looking, you shouldn't keep looking, first of all. That is called staring. When you break away your stare, don't look at the clock. Don't look at your watch. Don't look at your mobile. Don't do that. Look to the sides. These, when you look at mobile, your clock or your watch, it tells them you're busy. You may not be doing it intentionally. It's unintentional many times. It's just looking, what time is it? It's natural. So, but it should be our intentional response not to look. Okay, when you look away, look at it with a nod. Nodding says that, yes, I'm listening. It's a non-verbal cue. I've seen, I'm not sure if any of you have done it. Some of my, we've seen students in school where the teacher talks, they're falling asleep, but the nodding goes on. So I don't know if some of you are doing that for my class right now. And because the screen is off, I can't see. But when you're sitting with the patient, too much nodding, shaking your head gives a wrong message. When you look away, say, okay, I understand, or, oh, I see. Give them something of a reassuring short phrase to acknowledge that they are being heard. Next slide. Yeah, so the types of eye contact. This is very technical. You don't have to go by the rule. This is just to show you what is appropriate. Yeah. So look at the last image. It shows intimate gaze. Eyes and anything below the chin is not appropriate in a professional environment. You want to look away, look to the sides, to the ear, above the head. That's fine. Don't go below the chin. Next slide, please. Your body language. Your appearance, facial expression, posture, attire, all this matters. But first and foremost, let's go to the other 3 sentences below the picture. Be comfortable with yourself. Be confident, be welcome. This is what I want you to focus on. Whatever you do, how you carry yourself sends across the message very strongly. When you deal with somebody, be it in a team or with a patient or in the society, when you're trying to communicate something, even without saying a word, you're saying a lot with the way you carry yourself, your appearance. I'm not saying when you go, you have to put on a lot of makeup. No, not that. I'm not saying you have to be ultra fashionable. No, not that. Just be yourself. Your confidence will come through. Your genuinity will come through. Who you are will come through. And that is what enables people to build a trust. But in a palliative care setting, why is it more important? Your appearance should be appropriate. When you go into a community to visit a patient, it's better to dress where your attire should be appropriate. Your posture, if the patient is sick, looming over them, the patient is lying on a bed. If you can pull up a chair, sit beside them, right? It maintains that I'm equal. I'm sure most of us who have been to a hospital, who are admitted, or who have visited someone who's in hospital, or if any one of our loved ones was admitted for some reason, we have seen most of the medical professionals. I say this because I have been on the receiving end also. I've seen doctors come, they don't sit, right? They don't pull up a chair, and most of the times they don't sit because they're pressed for time. because that is not the culture within the medical community. That is that is part of the conditioning. They stand, they move over, they talk, and they may probably, how are you? They may pat on the shoulders. Dr. Raj always says that's wrong. As a doctor, he says that's absolutely wrong. Being patronizing is not, it's not, it will not be effective in your communication. Being a volunteer, your posture matters because you need to sit with them, and that has to come across that you respect them as a person. You're sitting with them. If they are standing, stand if you can stand. If you go to their homes, if there is no place to sit, stand, talk to them. Ask if they don't offer you. See, many times we have visited families where there's only one cot, one bed, and the sick patient is in the bed. The children, the parents are all lying on the floor. The spouse and all even the grandparents are all lying on the floor or outside the house because there's no place. So if I say, oh, I learned in communication, I have to maintain an appropriate eye contact, and because of that, I have to sit with the patient. No, that is not the point. It is important that the patient feels that he is not being patronized. The posture should be showing that you are interested and you respect. So if you can sit together or sit beside, or if you have to stand, stand. I had an encounter where one of the patients who I saw was having, again, CA rectum. I didn't know he was having cancer of the rectum. And I was this was during the first month that I joined Palliative India, and full enthusiasm, I was trying to make this man sit. I was saying, sir, sit down, let's have a chat. Sir, sit down, I'd like to take a case history. And he was like, no, I'll stand. No, I'll stand. And I couldn't understand. He couldn't sit because he was in pain. And I failed with all my degrees, with all my training. I failed to see that. I failed to understand that he was in distress. If only I'd asked him, are you okay? If you don't want to sit, that's fine. Maybe that would have helped. But I failed in that. So how you sit, stand, your handshake, how you, all this communicates two messages, mainly respect and that you're interested. Next slide. What you say, how you say really matters. Tone, pitch, speed, the speed with which we talk, the accent of our voice, too many words, too little words, all this matters. When we're talking with again, referring to the slide that was shown earlier, concise, clear, and complete. It really matters in this, how you say and what you say. Avoid jargons like adenocarcinoma. To be very honest, when I joined palliative care, I had no idea what adenocarcinoma or sarcoma means, no idea. So I had to understand, I had to Google it and understand what it was. Oh, it means cancer. Most of our patients, or at least some of them, may not know the medical jargons, and they need not know. And when we talk to them, interact with them, it is not a forum to showcase our intelligence. We just have to make it clear. Our idea is they understand what they're dealing with. It helps them take better decisions. It helps them take the next step. That is our focus. So avoid slangs. Like, for example, in Tamil, if they say, I don't know if there are any Tamilians, I'm told there are Tamilian candidates also, correct me if I'm wrong. If in Tamil they say, "Poi tunga," it means to go sleep. But in Malayalam, in my language, if they say "Poi tunga," it means to go hang yourself, right? So language barriers. So be careful what you say, and don't assume, okay, this could be what it is, so I'm going to use it. No, you might be saying the most inappropriate thing. And even in Kerala, even in Trivandrum where I am, there's a lot of different dialects, right? So they might say something which we might find offensive, but always bear in mind, it is never personal. It is never personal. So it is when we say something, we have to make sure that they don't feel insulted or hurt. Next slide. Moralizing. Exactly what we saw in the video. And many of you were saying she was not listening. When the patient said, I am in pain, I have pain, I'm not being able to sleep. She clearly said, if you had not been smoking, the attitude, the tone, the way she said, if you had not been smoking, you wouldn't have had this. Probably true, probably true. Too many smoking, too much drinking, or habits. But there are people who get the same disease without doing any of this, right? So moralizing, minimizing their problem, saying when she said, I can't sleep, she also said, you know what, even I have not been able to sleep. It's all part of it. Comparisons. If I am very hungry, right? And I'm saying, I'm hungry, if after a long and busy day, I haven't had my meals. By the end of the day, I'm hungry. And I'm, just like my niece says, I'm not hungry, I'm hangry, because hunger makes me angry. If I'm in that sort of mood, somebody comes and tells me, but it's okay. It's just that you missed a meal today. It's fine. It's not like you're going to starve. The people in some other countries are starving. Well, that's right. No. Similarly, if you say, you know what, at least with morphine you have pain relief. Look at the man lying in the bed next to you. He is in constant pain. It won't help. He realizes that man is in pain, maybe much more, but that doesn't diminish his personal experience of pain. Again, our intentions are always to provide them comfort when we compare, but be careful how you say it. Is it really necessary? Will it help? Next slide, please. Normalizing. Again, this is all part of it. Like the ASHA worker said, this is part of it. It should be okay. Normalizing it is not what we should try and do. Like I was saying in the slide is, do not normalize their problem. Like it's a normal thing. People with cancer will be in pain. Pain isn't necessarily a very common component, but do not normalize that. Acknowledge what they're feeling. Of course, I understand that you're in pain. I understand that you're angry or upset, and what you're feeling, it's natural, it's normal. I understand that. I can see that. Things like that. False assurance. Again, always I know the intention is pure. As volunteers, as social workers, as a team member, our intention is we need that. We want to give comfort to that patient and family. So we say, you know what, don't worry. Now we are in the best palliative care program. Now that we are here, why are you worried? There are so many things we may not be able to do. He might want to go to Disneyland for all you know. As a child, my last wish is Disneyland. Can you do it? Maybe not. Maybe you can. But unless you're sure of what you can offer, don't give them false reassurance. Don't set their hopes higher. Don't set it high. I'm not saying to kill their hope. Hope is what propels everyone forward, but it should be realistic. It shouldn't be something that cannot be achieved. That is why I said communication should be honest and true in every word. Next slide. Assumptions. Ask and listen. So most of you, I'm sure, were there yesterday when Smriti was sharing the experience about a man in pain, and his pain score was 6 or 7. I don't exactly remember, but then when he had said, a fisherman, he said, my only what I was worried was that my children, I didn't want my children to be fishermen, and that's exactly what they're going to be. And when they found a solution to it as a team, then they said, you know what, such education will be taken care of, and his pain score came down. So rather than assuming that his pain is because of his physical issue, ask and listen. Sometimes you'll have to ask. Sometimes you'll also have to listen actively with the non-verbal cues. That's very important. Stereotyping, labeling. I don't know if you've heard this, but many times we say, that man is an absolute itch. He's such a, he bugs me. When you say, oh, the boss, that boss is an absolute pain in the neck, or this person, Mr. X, is from this country. It's no wonder he is like that. He's part of, or assuming that because he has a disability, they cannot achieve something, or because they have cancer, they cannot achieve something. Ultimately, don't be judgmental. So these are all things that we know, and we all believe we are not judgmental. That's the problem. The problem is to realize at some point or the other, we are judgmental, even at the very subconscious level. Next slide, please. So when you finally sit down with the patient, make sure that you ask leading questions rather than asking closed questions, or don't ask, sorry, next slide, please. Senior, may I know what's happening?
Just one moment.
Yeah.
You want the previous one or next one?
Previous, please. Yeah. So when you ask questions, do not ask leading questions. You're feeling fine today, no? Better than yesterday, right? I'm sure your pain will, now that your children are education is taken care of, I'm sure your pain has come down, isn't it? So questions like that will not give them the room to actually convey what they want to say. Instead, ask open questions. How are you feeling today? Or how is your pain today? What are your concerns today? Or to make it more concise, or what are your concerns? What are your main concerns? What's been bothering you? And also give them that pause. Again, something Smriti said that she found it hard to deal with was silence, like a long silence. Most of us have difficulty being sitting silently. Sometimes it's awkward, but we need to pause. When you share an information, especially when you communicate a bad news, when you are dealing with collusion, when you are telling a young wife that her husband is dying, when you're talking with children, communicating to them about their parents' illness, pause. That silence is very crucial. It gives them the time to digest, not wholly perhaps, but they need that time. And it might feel awkward. It is difficult. That silence is so, it's so deafening. It's killing for us perhaps, but it's very important. Sometimes we'll have to rephrase, repeat what we said. Each time when the patient comes, we'll have to repeat. This is what we discussed that time. You might repeat the same mistake, so you might continue to do the same things. Volunteers, your community volunteers have said every week we go to the house, we have to keep explaining about how to take the medication. Probably he doesn't have that memory capacity at this stage because of the illness or because of something else. Maybe the wife, the caregiver doesn't have, but she's out, she's very overwhelmed. We may have to repeat. We may have to be patient, we may have to repeat. And also it's important to get a feedback. When I say feedback, even at the end of the session, there's a feedback, right? But this feedback is more about asking them, did you understand what I said? Could you please tell me what you understood from our discussion? But we have to be careful, because sometimes people might feel offended because they feel they are being treated as children. You want me to tell, why are you asking for a feedback? I am not stupid. I understood what you said. I don't have to repeat back to you. Fine? That's fine. So that's how it is. That's how it is. We don't want to make them feel insulted. Next question. Next slide, please. Humor, touch, smile. 3 very important aspects, but all three should be culture appropriate, gender appropriate, not the smile part, but touch and humor, gender, culture appropriate. And let me tell you this, I am a person who loves humor, who uses humor in my daily life. But not so, probably not everyone, right? Maybe some people don't get a joke. You say, right, if you tell a joke, there are people to whom you tell a joke today, they will laugh 3 days later. There are people like that. It is no fault of this. They are wired differently. So when you deal with patients also, some patients and families might enjoy a joke. Even your colleague, your team member, you might, to lessen the tension in the room, to make them laugh, to help them relax, is probably why you're cracking a joke or trying to present a situation with a humorous manner. But it might backfire. Always be prepared for that. And if it does, don't take it personally and use it, again, like I said, culture appropriate. Touch, from a very young age, the first thing when the baby falls down, what does a parent do? Stretch out the arm, right? Hug. There's nothing more powerful or healing than the power of a hug. Similar, it's just the power of touch. But again, it has to be appropriate. 2 aspects. The patient, family member, your team member, your colleague should be comfortable being touched. If not, and also you should be comfortable. If not, don't do it. It might create more problems. Smile is very important. We will look into that a minute later. Next, please. See, especially in this, just hold on with the video. Especially in this Corona age, it's very difficult to smile, right? Because we've all worn our masks. So even if you're smiling, nobody will see, correct? But it does. Your eyes speaks volumes. So even if your mask is on, they can make out from your face, from your eyes, that you are smiling. So sometimes when you look at your child, when you frown, the first thing they look at is your eyes. Your eyes speaks volume. If you have guests at home, unexpected guests, and if you want, husband and wife want to communicate something about food rationing and there's not enough food to be served, they might show something, nothing else. There's a lot of conversation happening between the eyes, correct? And you might show your children not to take the second serving, nothing is said. 1 blink of an eye, 2 blink of an eye, 1 look above communicates a lot. Similarly with smile, even if your mask is on, smile. It costs you nothing. It makes a world of difference to the people you are interacting. So the next slide, just give me 1 second. Are we out of time?
Almost, ma'am. Like we may have 10 to 15, max to max 10 minutes, because we need to have time for discussion as well.
Okay. So in that case, we'll just skip this video, because I'm going to talk about the good communication elements in the next couple of slides as well. And keep the room open, then we'll keep it open for discussion. Yeah. So.
Excuse me, meanwhile, everybody can put in their questions in the chat so that will speed up the process due to lack of time.
Thank you, Shanti. Thank you so much for
that. Shall we share the video now?
No, we'll skip the video. We'll just skip the video. We'll skip the next slide also, which says what was good, and come to the slide after. So bearing all that in mind, well, let's see how we can be an effective communicator. Greet. When you meet somebody, greet. Greet them in the most appropriate way. In a sense, if you are Corona age, so I don't know if a shake hand is appropriate. If not, stay away. Okay. So greet them, make the eye contact, introduce yourself. I tell this because it is important to know, especially if it is the first time that you're meeting this person, Introduce who you are. It's just your name. What is it that you do as a palliative care member? Who are you? Yeah. Introduce yourself. Smile. And before you start your conversation, ensure there is some sort of privacy where this person can talk to you, or you can talk to this person. Especially when you're talking to a patient and a family, they might disclose things about themselves, their concerns, their fears, their family dynamics, so many things that are private and need to be respected. Before, again, when you before you start, make sure yourself and the other person is comfortable. Sitting, standing, make sure you're comfortable. That person is also comfortable. Again, if you are, even if there is only one chair, offer it to that person, make yourself comfortable. The next slide, please. Again, ask open-ended question, listen actively. So this is one of the key points that that came up in the chat. Listen, and the second word is actively. It is not just the words that they're saying. So sometimes there are people who are not emotionally very expressive. That doesn't mean they don't feel it, right? So if you are, we have had patients, if you ask them, what is your pain score? So they will sit like this at the table and say, on a pain score of 10, on a scale of 1 to 10, what is your pain score at this moment? And she will go on to say 9. I'm like, sorry, it is 9. Now, yes. So you'll be quite surprised to say this is no expression whatsoever. The way they said, you'd think they're comfortable. So it's important to elicit, to ask, at also the same time, like what I failed to do with my patient who was suffering from cancer of rectum. When I met him for the first time, I failed to notice that he was fidgeting. And I was literally after him with the chair to make him comfortable, to make him to sit down so we can have an eye contact, all that. He didn't say, he felt embarrassed to say that he was having cancer of the rectum. And that to a senior government officer. This was way back in 2007. That was and I was fresh out of college. So later he told me, you are as young as my daughter. I was not comfortable. So, but I failed to do that. But these are things that we have to be mindful, active listening, listen to their concerns, fears, doubt, that something things that they don't need, that they may not verbally express. When they speak, do not interrupt. Do not interrupt. In fact, let them say. Maybe this is the first time they're getting that opportunity to share what has been bothering them. And encourage. When I say encourage, how do you do that? An occasional nod of the head. Oh, I hear. Oh, I see. I understand. Okay, then what happened? Really? I see. Okay. Phrases like that. Next slide, please. Ask about their concerns, not just physical. Like I said, we're so conditioned, especially in a hospital environment, to speak only about the physical issues. But we know to provide a good quality of care, it is equally important to address the psychological, the social and emotional, spiritual issues. So it is ask. For some people, you may not have to ask, they will say. For some, they need a push, so ask. Ask them what they know about the illness and the present situation. So if you are a volunteer who is acting in a capacity as a counselor, or you're the volunteer who's doing the first assessment of the patient, you may have to do this. You may have to gather information on what is the understanding of the patient, of the illness, of the present situation. Do they know what palliative care is, what they are here for? Sometimes the families may block, they may not let you do that. The family, you may have to talk to the family members. That is, you have to deal with collusion. That is all another whole other area for discussion. Clarify as and when necessary. Again, like I said earlier, you may have to repeat, you may have to elaborate, you may have to rephrase. Next slide, please. Give room for emotions. Like I said, many families, caregivers, they don't express their feelings in front of their patients. Patients don't do that in front of families because they are concerned for each other, because they care for each other. It's all bottled up. So maybe this is the first time they have the opportunity. Let them. If they want to cry, let them cry. If they are angry, let them be angry. But we as palliative care volunteers need to know, as an effective communicator, we need to know how to deal with a patient or a family member who's angry, who is crying their eyes out, how people, families who are depressed. These are specialized communication skills, which may, which will again need longer hours for discussion and training. When we share, be honest with your communication, and make sure you communicate it with your bigger team, because you as a volunteer alone will not be able to help them make a decision. You may have to communicate it with the right person in the team, so that after having a group discussion, get back to the family and help them arrive at the right decision. Sometimes, most of the times what I've seen is when we have patients in the IP, they open up a lot to our nurses, more than they do to the doctors, because they are with them most of the time. They tend to have more time to talk, and they are more, let's say, threatening or intimidating. So they are more open. They get a lot to share. And once you are talking to the to the family, conclude the interview by summarizing, by saying, so this is what we discussed. I understand these are your concerns. I hope you have a better understanding of the situation or this situation, or these are the things that I agree that I will look into and I will get back to. Before you close, always leave the door open, meaning ask them, is there anything else you would like to ask? Or is there anything else you would like me to look into before we meet for the next time? So, next slide. Another important aspect as a volunteer is you will have to report it to your supervisor or your mentor. Why? Because, and also documentation. Documentation is about date, time, who, what, when, where, why. All these you have to document, so that when in the patient, if your organization with whom you are affiliated allows you to do so, document it in that patient file, or else you keep a separate log, so that there is a clarity on information on where are we at now, what is it that we do, and how are we going to proceed. Report and discuss. This is another important aspect. It is called, is this the last slide? No. Next slide, please. So why I say report? No, the previous slide, yeah, critical reflection. This is something that we need to do as volunteers. Critical reflection is actually looking into ourselves. It helps us to hear ourselves. It helps us to have a third party, an objective view of what we felt, why we felt, what we said, why we said, how we responded, how we reacted. Okay, so that we can know, like, literally go back to all those personal factors that I was talking about when we communicate. This will help us understand, why did I respond like that? Why did I feel like that? What could we do better? How can I improve? So this is something that we do personally. And if then you discuss with your supervisor or your mentor, if you have one in your organization, it's good to do that. Or if you have a mentor or supervisor in another organization who can guide you, you need to practice this at least for a while so that you can sharpen your skills. Okay, next slide. Throughout the communication, in be whatever your role as a volunteer, if you're going to deal directly with the patient or caregiver, or you're going to be in the community mobilizing another team, or you're going to do awareness campaigns, whatever it is, you always have to be empathetic, respectful, genuine, because you can't fake it. No amount of education, degrees will give you that. You can't fake it. If you are not authentic, if you are not genuine in what you're doing, people can see it and you will fall. And be present. When you are with them, be there. Do not be distracted by, don't think about, oh, what am I going to cook for dinner tonight? Is my child screaming? I personally had to learn that now that I'm a new mom, I had to learn to be present. There were days initially when I used to think, is she screaming there? How is she managing? But I have learned to block that. Be kind to yourself and to others. One more slide. Can you go to the next slide? The next, just skip this. Yeah. Self-care, this is something I want you to really take a moment to look into. Now, as volunteers, we are all here to help. That in itself is a great virtue. But you need to know you need to take care of yourself. Say no. There are times when you feel burdened, when you feel you have to walk away, when you feel this is too much, you have to reach out for help. Take a break. I'll tell you one case, and I'll close with that. One case where one day I was with a patient doing my session in an inpatient setting. After I finished the session, I came out. There was a new patient in the OP. So one of the nurses came and said, you know what, I think it's good if you can talk to the mother. I said, okay, I'll do that. The nurse said, the patient is a young girl, cancer, intestine. I said, oh, too bad. How old is she? Probably, I don't know. I don't exactly remember which is intestine or stomach, but somewhere there. She said, probably early. She's a teenager. Yeah. I said, oh, that's sad. I just walked in. I said, okay, fine, I'll come. And I could see the woman, her mother, sitting there. She was stone-faced. She had a end of a sari around her head. So I'm thinking, oh, Muslim perhaps. She's got a sari covering her head. It's a Muslim. She looks stone-faced, no emotions. Probably in utter shock. But even then, she's a mom. Okay, fine, let's leave it at that. I was walking into the cubicle where the child was and moved the curtain. I asked it, there was a doctor there. I looked in, he nodded his head, gives me permission to walk. I moved the curtain and I was shocked. I was shocked because this girl was cut from her chest till her, what do you call, umbilical cord, wherever that thing. She was cut open. And there was this big suture marks, stapled. I think that's a modern technology where you don't have to literally use needle and thread. It's a big staple like suture. And there was fecal matter coming out of this, between this suture marks. I walked in, I saw this child, and my eyes popped out. Literally, I was in for a shock. And I remember I stood there and I just stared at this girl. And she saw me staring at her. That was the worst part. Again, a mistake, I said, I did. And I couldn't take it. With all these years of experience as a social worker, with all these experience as a trainer or a counselor, I couldn't take it. I couldn't manage. So I walked out. I said, give me a minute. I walked out. I couldn't breathe. I took a moment. I told the nurse, I said, what is she having? What is the scenario? Again, something that I should have done before I walked. So what I'm trying to say is there will be days when you face a difficult situation with the patient or family. You may be going through something difficult, whatever it is. You're doing a palliative care is an emotionally invested job. Whatever role you're doing, whatever capacity you're doing, self-care is very important. If you need extra help, reach out. If you need a break, take it. And if you're feeling overwhelmed, overloaded, say no, I can't handle this. It is for your good and for their good. Yeah? So self-care, again, I emphasize that I end with that note. Self-care is very important. And yeah, I'll stop with that. If there's any questions, we'll take. And I sincerely apologize for overrunning the time. And time management, probably not my forte. Again, I apologize for that. So there are any questions, Shanti will quickly.
Yeah, somebody like earlier when Vijay asked about community out of propaganda, you said we'll discuss in the end, towards the end.
Yeah. So Vijay, you had said you're working in a tech company, but most of the people are not aware. So what we do at Pallium India, or what I know Pallium India used to do when I was associate employed there, we do awareness campaigns. It's as simple as that. If you're interested in, if you feel the company is open to the idea, I'm sure wherever you are, there will be palliative care organizations. If not, in this age, because everything is through Zoom, Pallium India will be more than happy to reach out and help. I've not discussed it with the team, but I'm sure they'll be able to discuss and they'll be able to do an awareness program. That is the primary step. And the thing is to two aspects, to tell them what it is and what it is not. You know, it is not just cancer care. We have a lot of patients who are paraplegic. We have patients, we have had patients, I don't know if we have now, who are AIDS patients. We have a child, we have pediatric patients, geriatric patients. So I know for a fact there's an institution in Kochi that focuses mainly on psychiatric palliative care. It's called MEHIC. It is run by Dr. Chitra. So it's a wide range of diseases that cover under palliative care, and people need to know about this. And most of these palliative care organizations do have awareness creation and community mobilization as part of their palliative care program. So I'm sure they'll be able to, if you reach out to any one of us, or we can even put you in touch with organizations in your area who might be able to do this for you.
Thank you, ma'am. Thank you very much.
I think there are a few questions about will you be able to share the video? Video may be good communication. Senior, would you like to answer that? I'm not sure if Pallium India does share videos.
Actually, due to copyright issues, since these are the videos intended for NHSRC, we will not be able to share the same. Sorry for that.
Yeah, so I believe it is part training resource, isn't it?
In case required, we can show the video in good communication now if the faculty and facilitator are having time to spare.
I'll be more than happy to sit, but I'm not sure about the candidates and
How big is it, Sripriya?
Around 5 to 6 minutes.
So those who are willing to stay back, maybe probably they can, because some of them had requested for that. Probably they could do that because we don't want to miss that, right?
Yeah.
And one small correction, Aneeja, due to some, it is Sripriya who is doing the anchoring, not Sinia. Since it was given in the list, it was Sinia, so you kept addressing as Sinia, but it is Sripriya.
No worries.
That's fine, right? It's not an issue, but just a correction.
No, but thank you, Shandy. It's important. I personally feel that's important because you addressing a person by their name is actually important. If somebody calls me Supandi, I will not like it. So
it was unintentional, right? Because that's just a correction. Just for the record's sake, I thought it would be.
Thank you for that, and thank you, Sripriya, for being such a good.
No worries, because actually this was an emergency switch from our side as well, and we could not inform you in time. Basically, it was our duty to ensure that the faculty and the facilitator knows the details, but it was an unavoidable emergency, so we had to switch. And
that's okay. But when you introduced her, you said as Sripriya. So since I'm familiar with Sripriya also, so I could pick it up. So since I saw Senior the other day, so that's fine. So do we have after the since most of them would be going away, or if everybody's not staying back, I would like to give a word of thanks, so that as soon as the session the film gets over, that could be good. Thank you so much, Aneeja, for this great session where you communicated all the nuances of communication crystal clear, and sharing your personal experiences had simplified it further. I'm sure everybody enjoyed that, and it made it more meaningful for everyone, and everyone appreciates it. Thank you so much. For everyone, don't forget to join by 5 p.m. tomorrow. Thank you. Yes, the film, please.